morning. Good morning, everyone. I'd like to extend my sincere welcome, all of you, to the Cardiovascular Summit TCTAP 2018 on behalf of organizing committees. Today, I feel honored and excited to celebrate an important milestone in PCI 40 years history. Since the first PTCA was formed in 1979, interventional cardiology has experienced a lot of advances and achievement. I am immensely pleased to be part of this innovation. We started the first Angioplasty Summit in 1995, peripheral vascular interventions joining 2001, main and bifurcation summit joining 2008. We started FFR 2009, TAP procedures demonstrate 2011, CTO Lab 2013. This year we have a 23rd TCTAP meeting together. It's time to go beyond our limit and make another history by sharing mutual innovation and inspiration from all content that we provide in cardiovascular field. And this year's meetings, we have more than 5 invited faculty and around 4,000 participants from over 50 countries, 37 live cases, 397 lectures, 356 scientific abstracts, and challenging cases will be presented during the entire session. So furthermore, over 100 exhibit booths will be in attendance. So we have 6 live case transmission sites. It is really privileged to have world-renowned medical centers transmit variety of cases during the TCTAP. We are providing core session focusing on the 4 main topics: the CTO, endovascular, and coronary, and valve, and including the variety of content workshop, the complex live case demonstration, lab of interview, moderate, abstract, and the challenging case competition, and various satellite symposia with hot topics. And new clinical trials, including the most recent data, will be presented to the share in-depth discussion and the implication. Recent data from AMC in 2018 will be covered. Future clinical researches from the abstract submission are also highlighted. There's more over 10 international academic groups are joining this year and organizing partnership sessions to expand our horizon. And also TCTAP has grown with more than 50 global community supporters. We are very honored and proud to recognize the legend in the field of interventional cardiology. Please don't miss out TCTAP Award, the Master of Masters and Best Young Scientist Award, and interviews and the event on site. To expand educational sharing, TCTAP offers a wide range of platforms to enable ubiquitous access for the scientific program. You can see the newly added SNS in TCTAP 2018. So again, I really appreciate all of the faculty members, entire staffs, and participants who inspired and devoted this meeting. So hope everyone to have an enjoyable and wonderful experience during the TCTAP. Thank you. All right.
Dr. Bach, please join us to moderate. And the congratulatory remark will be by Dr. Stone.
Well, thank you. I'd like to congratulate S.J. Park and all his colleagues for now the 24th annual TCTAP Symposium. This course has grown over the years into one of the most important courses, I think, not only in Asia, but in the entire world. And when I think back as to why that is, I think that what S.J. Park has done in his entire career, but also as reflected in this course, is really combined the best of what interventional cardiology has to offer. And that is the combination of large volume experiences, learning from technique, learning from personal outcomes, coupled with evidence-based medicine, and that is the generation of data both from large observational studies and then randomized trials. And I think SJ really is almost unique among many operators in the world for his dedication to not just applying what he sees and what he does for his patients in the cath lab, but by taking the best evidence and the best learning from all of these types of studies and then applying them not only again to his own patients, but to that of his colleagues in Korea and the rest of the world. The importance of this course, I think, to us is reflected by the fact that almost everyone from Columbia University Medical Center and the Cardiovascular Research Foundation is involved every year. It's one of the highlights of the year for us, whether it's Gary, who's been, I think, integrally involved with this course over 2 decades, Marty, Roxana, Ziad, all the other operators at Columbia, and the people that are here. So I want to close by just welcoming everybody to TCT Asia Pacific. It's already been an amazing meeting. The next 2 days are going to be incredible. And I think finally this year is going to be very, very memorable to all of us because of the geopolitical events that are occurring on the Korean Peninsula. And the fact that 2 leaders of the 2 Koreas have reached out to each other and made such important, heartfelt gestures of peace is something that we're all going to remember, that we can place back to this date at TCT Asia Pacific. Thanks very much and enjoy the rest of the meeting.
Why don't you start the moderator? The presentation is a history of 40 years of the PTCA will be presented by Dr. Saroy.
It's a real honor to do that. As you could see, I have Associate Philippe Pascar and Holly Within. Over the last 2 years, both have collected anecdotes, stories, pictures, and we all have been part of it. So that's the book which has been published, and I will strongly recommend it to read that book. It's really very inspire many people of young generation and even old generation. I must say that Andreas Günzig is somebody you could not change the course of his life. If he has something in mind and you told him, don't do that, his usual response was, try to stop me. Of course, you are a giant because you have people have preceded you, and we should not forget Werner Forssmann in 1929, Nobel Prize, introduced in his cubital vein a catheter that he pushed until up to the right atrium. Then there was another giant, Mason Sones, with the angiography. He said one day, to open a door is to find other doors which are waiting to be opened. And it was indeed a Pandora box. Then there was Charlie Daughter, we used to call Crazy Charlie or Crazy Daughter, but Crazy Charlie basically has no respect for boundaries, and he created this coaxial type of catheter to open the vessel. And I think it's fair enough to say that in the Europe in 1968, we have in Frankfurt Eberhard Zeiler, who developed the daughter and attract the Andreas Günzig in the field. This is the famous pictures in the kitchen, the house of Andreas Günzig, his wife Michaela, but certainly Maria Schlumpf and her husband, a technical person, Walter Schlumpf, were very instrumental in gluing, putting wire, cutting with a cutter to finally create something that looks like a balloon angioplasty. But of course there have been many generations. I will never forget the generation 4.7 or 4.2, which was one of the first catheters. And that was the years of 72, 76. There was some serious success in the superficial femoral angioplasty at that time in Zurich. And then in October 75, there was this famous poster. Not too many people saw the poster, because if you look at the pictures of the heart behind the shoulder of Andreas Günzig, it was not very appealing. I remember Paul Lichlen attracting Spencer King and say, you have to see this poster. He has the support of a great surgeon, Marco Turina, but there were many people whispering, this will never work. Then many people have forgot this great man, Richard Meiler, who had a lot of trouble with his heart and his vessel. But at some point in San Francisco in May 9, the surgeon of Richard Meiler, Elias Anna, agreed to, during a bypass operation, to do an arteriotomy, introduce the balloon angioplasty in the anterior, in the left anterior descending artery, dilate the anterior descending vessel, did not recult debris, and there was a significant reduction of the stenotic lesions. So this was the first perioperative, intraoperative coronary angioplasty. Now, if you look at the next step, it was on September 1916. I remember very well Hans-Peter Kainbühl, which was not favorable. He didn't like the procedure of Andreas Günzig, and it is this man. This man is a surgeon, Aiken Senning. He's not only a surgeon, but he's a pioneer. He's the guy who introduced the first pacemaker, implantation of the pacemaker, and he's also among the pediatric surgeon known for the Senning operation. And it is Senning who said to Andreas Günzig, I will be there by the time to do the first case. By the way, it was his patient, and I'll help you later if it doesn't work. And you recognize Bernie Meyer, which is on the panel. He should be here behind the lectern to tell the story, because he's really the first to show all these development. Now, I like this man very much, Dolph Bachmann. I'm not so sure that the sounds will be there, but it doesn't matter because you have the text. If you can put the sounds, it will be even better. What he say in this interview is absolutely remarkable, because he explained how Andreas Günzig told the detail very simply. He was completely transparent, as you could see. He made a sketch. He explained everything to him in simple words. He told him that there was a bypass operation. He told him what was a dilatation. He told him that he has never done it on a human being. Of course, he had done animals, dogs, a monkey, but it will be the first time that he will do in the human. He has done that too in the peripheral vessel, but peripheral vessel is not coronary, and it will be the first time in the human heart. And the last part of the interview is very moving, because first Andreas said that he was a young man with a good cholesterol and the artery was basically healthy. And then there is a question, were you afraid of? And he said, no, everything was so clear. He was a layman, but he understood everything. And he said, I understood what was going on. And he said he could see his face and and there was no reason to worry. I was 100% convinced that I would be successful, and the last sentence he said is because Andreas Grünzig was explaining so clearly that stuff. It's a beautiful interview. So this is before, this is the peripheral injection, this is immediately at the time of the balloon angioplasty, and after. And I've been part of this generation where we were not so much looking at the fluoroscopy, we were basically looking at these two pressure tracing. We were injecting a little bit contrast here, and then we were inflating the balloon so the pressure is down. Mine, it doesn't take too long. I mean, we were doing that for 10, 12, 14, in this case 17 seconds, deflating the balloon, and if the pressure was coming on, we were not calling the surgeon. But if the pressure was down, that was the moment to say to the nurse, please call the surgeon. And what happens is that very quickly, Hans-Peter Keinbühl was not happy about the fact that there were so many visitors in the lab of Andreas Grünzig. So with the technician of Andreas Grünzig, they decided something quite remarkable. They said, okay, I'll do the case in the lab. There will be a camera and a sono, and you will transmit the case in another room. So on August 78, there were 28 participants watching this first course by tele, like we do today, and there were 7 patients dilated on that day, and everybody agreed that the man was extremely brave and honest. Now, it was not so easy because I think in August 79, he presented the result of the first 50 procedure at the American Cardiologist and Cardiac Surgeon. And immediately they were a contender, and the contender was an Hungarian-born North Carolina cardiac surgeon, Francis Robicek, not a very nice name. And he was obviously the spokesperson of the cardiac surgeon, hostile to the balloon dilatation, and he tried literally to demolish the Andreas Grünzig therapeutic approach. What kind of miracle procedure is this? If 1 out of 5 patients needs to be operated on? What kind of miracle procedure is this if balloon cannot be advanced in 1 out of 3 coronary arteries? What kind of miracle procedure is this if this balloon job close up again in a matter of time due to restenosis? Any medication with such a failure rate would yank it off the market. The answer of Andreas was every one of these patients was scheduled for bypass surgery in the first place. Success rates are improving rapidly with refinement in the technique. Better selection of indication should diminish the restenosis rate. Now, on one day, still in Switzerland, going back from Davos in the same train as Spencer King, he said to Spencer King, I'm not happy here, I mean in Zurich. I can use the cath lab only 2 days a week. I want to teach the technique, to shepherd it, and to become a professor. And the answer of Spencer King was, why don't you come see us and have a look at Emory? And that's what he did. And Andrea finally obtained what he needed, whereas he was almost rejected and treated like a pariah in Europe. Now then, in the years to come, there was competition. Andreas wanted to keep the treatment very simple and safe and build up very gently. It was about 10% of the patient. Then there was this genius, John Simpson, in March 1982. you came suddenly with the steerable Y. Of course, we were losing the pressure at the tip of the balloon, and Andreas was not happy about that. I remember very well the debate at the American College, but the success rate increased from 60 to 90%. And then there was the other guy, extraordinary person, Jeff Hassler, who has broken new ground performing coronary angioplasty on the largest possible number of patients with coronary artery disease. He did the first PCI for myocardial infarction. You see the distal injection, the inflation of the balloon, and the immediate result. And the controversy between the two men passed a few years, but finally, in July 85, Andreas would finally recognize that Jeff's intuition to broaden the indication for coronary angioplasty has been the right one. In July 85, that's the last time I saw Andreas Grünzig on the beach in Monaco, in the Big Island. And then just a little bit later in September, he was a pilot. He had a single engine and then a double engine. I was told that he was for the first time piloting with the double engine, and then he crashed coming back from, I think, Miami. There was a storm coming from Mexico. So I like this. This is a Gaelic music, to tell you that in October 1985, a plane crash claimed the life of Andreas Grünzig, a year which has already seen the loss of 3 other leaders, Judkins, Daughter, and Soames. And of course, these men in 1985 had introduced a therapy which are today the most common medical intervention in the world. Then came Julio Palmas with the stent, and I had the pleasure to make 4 handbooks on all these bare metal stents. Of course, there is also an history of the stent. This is Alexis Carrel in 1912, Nobel Prize. He put this aluminum tube in the aorta of this dog who survived 90 days. By the way, there was no photography at that time, so what you see here is what we call a daguerreotype of the dog. Amazing enough, Charlie Daughter put the first stent in 1969 in the femoral of the dog. They were clotting and stenotic, but it is until Julio Palmas, a radiologist from Buenos Aires, that we start to see workable tool. And Hans Wollsten, who has invented the way to print newspaper on both sides, on thin layer of metal, who developed the self-expanding, and as a rich Swedish, joined Switzerland and went to Lausanne. Then we have Jacques Puel with the first stent in March 28. Then you have, at the time of the course of Ulrich Siegwart, the treatment of the first acute occlusion. Then we have Gary Rubin and John Douglas with the bailout, the John Turco-Rubin device. And finally, Richard Schatz and Julio Palmas. This is in Sao Paulo in December 31. Amanda Souza, Eduardo Souza, Julio Palmas, Richard Schatz. This is the first patient. The morning they came, the vessel was occluded. So they were very brave. They put the Palmas Schatz, and that was the first opening of the occlusion. Then I have to mention my friend Antonio Colombo, who introduced the IVUS and said these stents are not properly implanted. Then there is somebody that we have maybe a little bit forget, Pierre Barragan, which introduced the diclobidine. And it is from Marseille to Toulouse and Paris, Marie-Claude Maurice and Beveniste, who made the combination of diclopidine and aspirin, putting an end to the anticoagulation in stenting. I had the privilege with Fishman to do the first two randomized trial, the Benestant and the stress. We reduced the restenosis rate by from 32 to 22, and the stress from 42 to 31. This is the next step, flying to Sao Paulo on a regular basis. This is the drug-eluting stent, the first Sapphire. You recognize Alexandre Abezaid, Robert Falotico, the father of the Cypher, Eduardo Souza, Amanda Souza, Brian Firth, and myself. And this is the follow-up of the first 45 patients, 15 in Rotterdam and 30 in Sao Paulo. Shortly after, we prepare with Marie-Claude Maurice the Ravel, which was, of course, a cultural shock for the people. We didn't have access to the late-breaking session, but nevertheless, we show a reduction of the restenosis rate from 26 to 0%, and the MACE from 28 to 5.8. And then there were many people involved in the adjustment of the treatment: aspirin, clopidogrel, aspirin, prasugrel, aspirin, ticagrelor. Then came the bioresorbable. Indeed, why a permanent scaffolding? If you have a dissection, that 30 minutes of scaffolding will be enough to resolve the problem. If you want to avoid a restenosis and the constrictive remodeling, probably 6 months will be enough. So why a piece of metal? And it's clear that there were some physiological consideration. We will restore the vasomotion. It looks nice, but also we believe that we could eliminate the late stent thrombose, short the DAPT, leave the way open for cabbage, and reduce the iterative revascularization. I would never forget my friend Hideo Tamai, who came to Rotterdam. We implanted the first 7 bioresorbable stent. Then he went back to Japan to finish the series of 50. But as you could see, the result was not so pleasant. 18 iterative revascularization versus 5.3 at the time the Cypher coming. John Ormiston was lucky. Just a few days before me, he could implant the first bioresorbable scaffold eluting drug. And you know the story. It was originally nice, but after the major trial, it became clear that there were more target vessel myocardial revascularization, more clinically indicate target lesion revascularization, and more definitive of probable stent thrombose. So that's basically the story, going from the balloon to the stent, from the drug-eluting stent to the BRS. And the BRS story is not finished. I think there will be a revival, but clearly even the effect of balloon angioplasty can last very long. This is an American patient treated by Andreas in April 1978 with a quite nice result, and about 24 years later he got an acute myocardial infarction at the age of 74. He was nicely treated by balloon and stenting, but by the time Andreas, the successor of Andreas, looked at the LED, which was still intact, confirming that the result of balloon angioplasty can last very long. So this is a beautiful pictures of Andreas in his airplane. I like that sentence, which has been quoted many, many times. Whatever becomes of the method, I have left one mark on medicine. I've shown that men can work therapeutically within the coronary arteries in the face of an alert and comfortable patient. And all of us, every time we dilate a lesion, we feel like reliving the dream of Andreas. Thank you.
fantastic presentation. The next topic is the Asian perspective of the 40 years of the PTCA. Will be presented by Dr. Lim.
That's terrific.
First of all, I'd like to thank and acknowledge Dr. Park and the organizer for giving me this honor to speak on behalf of my Asian colleagues, the Asian perspectives in 40 years of PTCA in this very historic as well as peaceful meeting as we've heard this morning. In 1999, in an editorial, we anticipated that an Asian Pacific bloc for coronary intervention would emerge to complement the existing and more matured European and American blocs. An emergence of this bloc in Asia would add significantly to the globalization of interventional cardiology. This has indeed come to be realized, and the Asia-Pacific bloc, now with the help and collaboration of our more advanced Western colleagues, have come up with awesome meetings like this particular one, TCTAP. But there are others in China and in Singapore that have reached global international standards. When Dr. Park took over as president of the Asia Pacific Society of Interventional Cardiology, he made groundbreaking changes, as have been highlighted by Dr. Greg Stone in his very unique and scientific way. But he also wrote this in 2009 in CCI editorial that he anticipated that APSIC is ready to jump. Indeed, it has jumped. And of the countries in the Asia-Pacific region, as you have seen here on the left, this most recent data collected show the rapid growth of PCI or PTCA in countries especially such as Asia, India, Pakistan, Thailand. Whereas other areas is just starting, Cambodia. And the more advanced nations such as Australia, Singapore, and Japan has reached a plateau or buffer state, which is easier seen in this slide. The number of PCI in China and India has skyrocketed and went out of scale on this graph. You can see between 2010 and 2017, India has increased from 67,000 to more than 300,000, and Japan has reached 250,000 and now 350,000. But China increased from 1,200 in 2000 to 660,000 at the present stage. Not only has the PCI grown rapidly in this region, the Asian leaders and operators have contributed significantly to global PCI advancement in technical and clinical areas. We've heard that the first biodegradable stent was innovated by Dr. Tamai. The Asians have also helped to establish transradial coronary intervention as a routine access for coronary intervention. I think, as you've heard in many presentations in this meeting, Asian contributors have made significant inroads to coronary imaging and physiology-guided PCI, as well as a few important clinical trials that change medical practice in terms of pharmacologic and device therapies. But very significantly, Asians have contributed to advance PCI for complex coronary artery disease, especially involving the left main bifurcation and the chronic total occlusion areas. With this technical advancement, they are in a position to demonstrate the feasibility of total coronary revascularization by PCI alone, which is a very routine practice in this region. Here we see the Asian contributions highlighted. The first biodegradable stent of Dr. Tamai has been highlighted by Dr. Patrick Saroy. And after 10 years of follow-up, it has shown that it has been a safe and feasible technology. Dr. Saito of Japan, in his very delicious trial of tempura very early in the early 2000s, have shown that this access has significant advantage over the femoral approach in reducing major bleeding. This country has contributed very significantly to coronary imaging, and one of the first coronary OCT studies was conducted by Dr. E.K. Yang, who is Korean but now in America, together with Dr. Park and his colleagues here in this country. And we've all benefited from this very important technology, as well as many flow-guided PCI technology performed in Asia. In the pharmacological area, Dr. Han from China has published this bright study showing that the use of bivalirudin during primary angioplasty can reduce bleeding while maintaining ischemic efficacy with no increase in stent thrombosis. Our course director for this magnificent meeting, Dr. S.J. Park, affectionately known also as Left Main Park, has not only shown us who to treat, but when and how to treat left main disease. And we've shown 3 very excellent examples in a live demonstration this morning. He's also a pioneer in establishing the fact that left main treatment by intervention is an alternative to bypass surgery. When you have complex distal bifurcation, Dr. Chen Xiaoliang of China has come up with this very innovative DK crushing technique, and recently he has shown that it's superior to the one stent provisional stenting technique. This is still evolving. But the most unique contribution from this region is the technical advances made in recanalizing CTO lesions. And this was first pioneered by Dr. Kato with his CART and reverse CART techniques, which has now evolved into a specialty of its own. And in this meeting, one of the 4 major topics and a dedicated site is to solve CTO intervention. Why is this important? It's especially important in Asia because bypass surgery is not easily accessible or available in many hospitals in Asia. We all know that these are 2 very different modalities to completely revascularize coronary arteries. They are non-equivalent in technical complexities, but the most important question asked, I think it was by Greg Stone, that these 2 non-equivalent procedures, do they have equivalent long-term outcomes, especially for complex diseases? In Asia, there are non-equivalent access to bypass surgery, unlike the West. And these are the main reasons. There are technical preference, cultural preference, technical constraints, as well as economic constraints in many Asian countries, developing countries. Asians are in general reluctant to have open chest surgery. As a result, the ratio of PCI to CABG varies from 3 to 1 to when it is non-existent infinity. and some of them are usually up to 20 times higher intervention by PCI compared to CABG. CABG surgery is not routinely available in most hospitals in Asia, so there's no choice but to treat all complexities of coronary artery disease by PCI alone. In terms of building up surgical units, Asia lacks the surgical expertise as well as training to build surgical teams, whereas PCI is a matter of training of a single operator. Finally, cost is always a constraint in many developing countries in this region. To fully revascularize or to achieve complete coronary revascularization, one of the main barriers is CTO. And we all know that the current evidence and guidelines tell us that with complex lesions of syntax score greater than 33, surgery has better long-term outcome. And one of this reason is incomplete revascularization in the intervention arm of the major trials that we now use to write our guidelines, such as Syntax, Excel, Nobel. As you can see here in the Freedom study, when the Syntax baseline score is low, they are always revascularized by intervention. When the Syntax score goes up, the residual Syntax score remains high, and the untreated lesions usually are the complex ones that we're now focusing on: CTOs, bifurcation, long and diffuse lesions. The main technical challenge is actually in CTO, where half of complex lesions, the lesions were not treated when it's a CTO. Therefore, to achieve complete revascularization by PCI, to be able to recanalize CTO lesion is vital. We all know that the operator competence in as early as 1993 were based on volume. So if you are less than 200 per year operator, you are class A, and if you are more than 500, it's class C. This correlates actually quite well with the Syntax score of less than 22, 32, and 33. But I would like to propose an addition of a fourth class, which is the ability to perform CTO with high success rate. So I urge hospital administrators, directors of cardiology, and the cath lab to focus in public and private hospitals as well as research institute and training centers the abilities to train a full range of capabilities for the interventionists. Because in Asia, when there's no bypass surgery, all lesions have to be treated by PCI, and that in fact is routine clinical practice now, despite the guideline. For complex lesions of Syntax score greater than 33, they will tackle them all by intervention. So it's very important to show the equivalence of the two treatment modalities, especially in complex disease, that hypothesis that equivalent long-term outcome after complete revascularization, I stress complete revascularization, as assessed objectively by a residual score of less than 8 by coronary intervention, stenting usually, versus bypass surgery. And the difference of this with the current existing evidence is that the entry point of current comparative trials are made based on Syntax score and not the extent of revascularization. I'd like to propose a trial, complete coronary revascularization by bypass surgery versus stenting, or the CBS trial, with one arm using the best stage clinically and FFR-guided PCI, which is the technology now, performed by D-grade operators, versus one single bypass surgery that normally achieve RSS of less than 8 and follow this in the long term. So in conclusion, my personal perspective of the Asian perspective in 40 years of PDCA is that although there's rapid growth of PCI in Asia, it is still heterogeneous. Asian contributors have made significant scientific, technical, and clinical areas towards global PCI advancement, and Asia's routine stage clinical FFR-guided PCI to achieve complete revascularization must be compared to the best Western bypass surgery for complex multivessel disease. A well-designed trial involving Asia and the West should be designed to prove equivalence of long-term benefits for both therapeutic strategies. I'd like to appreciate the assistance of Professor Tan Hui Chim, the current president of APSIC, and Ms. Jo Chan, the secretariat, for their assistance in preparing the data. Any data presented was sourced from personal communications and publications, and I take responsibility for all data inaccuracies and omissions of scientific contributions. Thank you.
If you any discussion about the presentation? Okay. If there is no discussion, we will move to the next session, TCTAP Award 2018, Master of the Master. This award will be presented by Dr. Pa, S.J. Pa.
Okay. Right, this part is one of the highlight of our TCTAP meeting. So TCTAP Award the Master of Masters. Thank you everybody for joining our special ceremony for 8th TCT Award the Master of Masters. This award was established in 2011 to recognize and acknowledge its meaningful contribution to the development of cardiovascular medicine and growth of TCTAP. And the past recipients are Drs. Nobiosis, Maridion, Dr. Colombo, Gary Min, Spencer King, Barry Rutherford, and Edward Gruber last year. So I would like to introduce this year's legend heroes for 8th Masters Award. Oju, give me. You have also been a huge contributor to TCTAP since its beginning, with your persistent enthusiasm of imparting knowledge to the audience. It has shown immense improvement to the meeting to be grown into one of the leading conference in the Asian Pacific regions.
David is one of the most sought-after lecturers and speakers in the interventional cardiology world. And the reason is that David has the unique ability to combine the delivery of a scientific message with engaging humor.
Your contributions in your science, the care of patients, and your inevitable way to communicate, particularly in the TCT courses over all these years and many other venues, has been quite extraordinary.
Thank you so much for all your contribution in terms of teaching, in terms of presentation in late-breaking clinical trials, and of course, from a personal standpoint, all the superb questions you've written for the American Board of Internal Medicine Interventional Cardiology Board.
I am wild about doing what I do. I'd like to be able to do it for another 50 years. And so this has allowed me the chance to get to know the broad sweep of cardiovascular disease and cardiovascular care.
All the history of interventional cardiology is full of memory and key contribution of David Holmes, starting with angioplasty, with data collection, important NHLBI registries, stents, and now with structural heart disease like atrial appendix occlusion.
We belong to the same generation already with internal medicine and cardiovascular training in 75, 76, so we start to appear on stage of the ACC and American Heart Association at the same time. And you would not believe, but he was a very shy speaker who grew into a very astute debater, feared by many other ferocious debaters.
But David is really a very special person. He's been involved in almost every aspect of the development of percutaneous coronary intervention from the beginning, and his truly novel insights and leadership and the way he looks at the pathophysiology of coronary disease and the treatment of patients has really helped pave the way for the way we've developed the entire subspecialty.
Now, I wanted to congratulate David on receiving this remarkable award.
I'd like to say that you are one of my best friends and inspirational teachers throughout my lives, professionally and personally.
I can think of nobody else who is more deserving of this year's TCTAP Masters of the Master Award.
Thank you for your amazing contributions to the field of interventional cardiology. You're a true master.
The dreamers of the day are the dangerous one because they may act out their dreams with open eyes and make their dreams possible in this idea. Because I want you to dream wildly with your eyes open and make your dreams come true.
was tremendous. I never realized who exactly that was. But I think the most important thing about that, this is a terribly important thing about that, is that every time something like that comes up on the screen, you say, oh my God, do I have a different suit on? Do I have a different tie on? Have I spilled on my suit and my tie? And I need to remember and let you remember that there was only one time during that whole video that you saw me with the same suit and the same tie and the same shirt on. And you didn't recognize it, so I'm very pleased about that. So I don't have any slides related to that specific presentation, other than to say a couple of different things. As we heard incredible information from the history of intervention, we learned a couple of things. We learned that imagination is stronger than what we used to think was knowledge. Imagination is stronger than what we used to think was knowledge. Used to think that knowledge said a chronic total occlusion is a chronic total occlusion, get over it. We learned this time and in the past from S.J. and his colleagues that indeed knowledge is stronger than what we thought was knowledge. The second piece of information was that dreams are more important than facts. The dream of saying, gosh, left main disease only belongs to the surgeon was just a dream. And S.J. working on that said, well, it's just a dream. You wake up in the morning and the dream is not there anymore, and you can then move on to what you wanted to do anyway. And so the second piece of information is that dreams are not nearly as important as imagination. The next piece of information relates to each of you in the audience and is incredibly important that we don't talk very much about. A man by the name of Fulgham wrote this. He wrote, to each of you, you should listen to each of you, the fact that says, live a balanced life. Live a balanced life. Live, dream, drink, not so much as you did last night, but drink, and dance, and sing, and rejoice every single day, and then work every single day. But remember, in all of these things that you do, remember wonder. Isn't that an interesting concept? Wonder. As a kid, you were given the duty to go home and take a little tiny seed and put it in the bottom of a styrofoam cup and put it in the sunshine, and then put a little dirt on top of it, and behold and wonder, the seed grew and the roots grew down and the plant grew up. How did that happen? How did that happen? That is the wonder of what we do, of what you should do. And so the most important things about this are to look and to wonder and to be amazed and to do those things that you do to make a difference for you, for your wife who is here, for your family who is here, for your patients who are here, for the world that is here, as you then move to make your dreams real by dreaming them with your eyes wide open. Dream well. Live wildly. Have the best time ever. Because it doesn't get any better than this. And that's the real deal. Thank you for this wonderful award. Thank you for S.J. and the things that he does, the things that you do to make things happen going forward in your journey, on your journey. Thank you. We're going to talk about something next that is an unmet clinical need that you, every single one of you need to be involved with, because it is a huge annuity project. We get concerned about the fact that at some point in time we will grow out of coronary disease. We haven't as yet. We probably won't. But going forward, we need to realize that atrial fibrillation is a huge deal, and the things that we can do about atrial fibrillation are incredibly important. I don't have any relationships related to that, other than the fact that I have grown to that point in maturity that I might become good friends with other people in my age who become good friends with strokes. Given the fact that 30% of all strokes in patients over the age of 75, I'm not yet 75, but if I were 75, 30% of all strokes in patients with age greater than 75 are related to atrial fibrillation. And this is that issue that you never want in your medical record. And it comes from this incredible image, this credible graphic from 2006 that said in this specific image in panel A, there was a clot in the left atrial appendage. In panel B, your radiographer, your echocardiography called and said, gee, could you come here right away? We've got some problems here. In panel C, that moved out to play in the left atrial appendage and the left atrium, and in panel D, it was gone. At that point in time, there was hemiplegia. And that then is the pathophysiology of stroke. And it's the most single common complication that is feared of cardiovascular disease, higher mortality and morbidity. 20 to 40% of all strokes related to non-atrial fibrillation. If you were to say atrial fibrillation occurs in 1 in 4 of you in this arena over the age of 45, 1 in 4 of you will develop a close, upfront personal experience with atrial fibrillation. That is true. That is true. We know that up to 15 to 20% of all atrial fibrillation strokes are fatal. They're high recurrence rates, and there's the cross of treatment and prevention. This is a tough slide because we're going to talk about equipoise. Equipoise is an interesting concept. We use that in randomized clinical trials all the time, and we say, well, it's a state of genuine uncertainty, and that is requisite for a randomized clinical trials. It is much more complex than that, because there is the issue of theoretical complexity and theoretical equipoise versus clinical equipoise. And that makes a huge difference for you and an even more important difference for your patients. What could we say about the issue of non-valvular atrial fibrillation that is not really subject to any equipoise things? We could say that all risk scores are imperfect, although patients with non-valvular atrial fibrillation, they should all be evaluated for risk of stroke and systemic embolization. Everybody should have that. No matter whether you're a dilator, whether you're a balloon person, whether you're a pill taker. There are several strategies for stroke prevention in high-risk patients, and patients should be given the information about these strategies in a way that they can understand them. You need to talk in a way that they can understand them, because patients are increasingly at the center of shared decision-making. This is the menu that you're going to talk with your patients about. We went to a great dinner last night. There was a menu. I couldn't read it, but it was really good. In the menu that you're going to talk with patients about, there are these things on the left and there are these things on the right, and you're going to try to have to guide them through to make the appropriate decision. And so we give them the pieces of information that they know. We can say about anticoagulation, it's been studied and found effective in large studies, and it's associated with bleeding. You don't give somebody a drug that prevents clotting that doesn't cause bleeding. That NOACs are better than Coumadin, that compliance is an important issue. There are the issues of costs and convenience. Anticoagulation does not prevent all strokes. If we say to a patient, we're going to give you a drug and you're not going to have to worry about a stroke, sort of a bad deal. And hemorrhagic strokes have the highest morbidity and mortality. Let's then say, give this piece of information to the patient to file away. And this is the oral anticoagulant therapy prescription in patients in the NCDR Pinnacle Registry. It was 430,000 patients with atrial fibrillation. You saw them in the office and you said, you've got atrial fibrillation, I've got a drug for you. It's going to prevent your subsequent stroke. But what did they find? That overall oral anticoagulant prescription prevalence did not exceed 50%, even though we promise. We say to ourselves for sure, we give every single patient at risk for stroke with atrial fibrillation, we give them an oral anticoagulant. Somehow that doesn't happen. Only happens in your system 50% of the time. And so they found that there was a plateau of oral anticoagulant prescription with less than half of the high-risk patients. Those patients that have the best chance of benefit from it, they don't get it. You might say, well, that was only 430,000 patients. Gosh, maybe that was a select group. Well, this is an administrative database. There are some problems with that of 66,000 patients who were treated with apixaban or rivaroxaban or dabigatran or warfarin. Had a CHADS-2 VAS score greater than 2 and 90%. They were 73 years. They had a HAS-BLED score that was high. And this is what they found. You have given that drug to the patient and you have said, this is the best thing ever. Well, when you look at them at a median of 1.1 years, this is the data of the number of patients who are on that drug that you gave them. It's about 50%. 50% said, you know, I just never got around to it. In fact, it bothered me a little bit, and it was a little costly, and I had to remember to take it every day, and so I didn't take it every day. How many of you, when you go to see the doctor to get your cholesterol checked, you know what's going to happen in 2 or 3 weeks? In that 2 or 3 weeks, you say, I'm going to take that cholesterol medicine, I'm going to lose weight, I'm going to exercise like crazy. Well, this is a group of patients in whom we give them that drug, and they don't do any of those things that you told them to do. You might say, well, that was just in the United States. Well, how about in the rest of the world? This was data from 164 sites in 64 countries. The use of oral anticoagulation prescribed was in 58% of the patients worldwide, ranged from 11% of patients in this world who were given anticoagulation to prevent stroke. And part of the issue is this: willpower lasts about 30 days and is soluble in alcohol. We give somebody a drug and we then say, take it forever, and the patient says, my God, I'm all over it. About 30 days later, maybe not so much, you know. I didn't take it yesterday, I felt okay today. Maybe, well, I don't know. Maybe I'll just hold off on it for a while. And so willpower lasts about 30 days and is soluble in alcohol. The next part of that equipoise equation is the devices for local site-specific therapy, which have been studied and found effective in randomized clinical trials. They have small procedural adverse events. That is true. We need to realize that. There's a major reduction in hemorrhagic stroke. There's an improvement in survival. How many things in this audience do we do to patients that improve their survival? Not nearly all the patients. They're associated with decreased bleeding because anticoagulation is usually avoided. They do not prevent all strokes. If you have a patient with non-valvular atrial fibrillation that has an intracerebral aneurysm, it's not going to prevent that from bleeding. They do, however, eliminate noncompliance. And so if we look at the data, we have an increasing amount of equipoise data to present to the patient. These are just the clinical timelines of the different Watchman trial devices. Is it perfect? It's not. Are we trying to cover the waterfront? We are. But we do know that in terms of compliance with patients, it works. About 95%, 98% of the time, there's a procedural success. So if the patient says, well, how often is it going to work? You could do this, you could give me a prescription. I know that you'll give me the prescription. Suppose you give me a device. How often does that work? Well, it works about 95 or 98% of the time. You might say, well, I'd like to get off anticoagulation, whether that be rivaroxaban or apixaban or edoxaban or warfarin. About 98% of the time at 1 year, they don't need to be on it. This is an extraordinary piece of information in the equipoise equation, is that if you were to look at the mortality reduction with a device as compared to with dabigatran, 1 or 2 doses, rivaroxaban or bixaban, it is much bigger effect on the reduction in all-cause mortality. That's the information that's available that we need to present in the equipoise equation. Patients are concerned about bleeding. What do we know about bleeding? We know that bleeding after left atrial appendage closure compared to long-term warfarin is 70% less. Doesn't get much better than that. It does not guarantee that the patient will never bleed. But it's a dramatic reduction than if they're taking an anticoagulant. And finally, if we were to look at this patient level analysis of how well they do, well, there are some issues early on with an ischemic stroke. If we don't know how to do the procedure and we get a brain embolus from air, they're going to have an event. But the most important thing is that cardiovascular death or all-cause death is reduced by about 40%. We have nothing, pretty much, in the field of interventional cardiology that reduces mortality by 40% over the course of the next couple of years. And that is a reduction that is seen in major bleeding is decreased by 50%, provided that we use vascular closure devices and know how to do it. Vital piece of information is to say, well, what if I'm one of the bad ones? What if despite this device I get a stroke? We have the information that in those group of patients who are treated with a Watchman device, if they develop a stroke, which is uncommon, the chance of it being disabling or fatal is about 60% less. A hemorrhagic stroke in a patient who is on anticoagulation is awful. It is the worst, the longest or the shortest, because some of the time it ends very, very quickly, but it is clearly the worst. And so what then could we say? Atrial fibrillation and stroke prevention is a global unmet need. It's been used mainly as second-line therapy, although first-line therapy with anticoagulation, as we have seen, has some significant gaps. Left atrial appendage occlusion is effective with a dramatic reduction in hemorrhagic stroke, significant reduction in mortality. It's a 40% reduction in mortality. Significant reduction in bleeding of 50 to 70%, and it can be used in those patients in whom anticoagulation either can't be used or is non-optimal. And there are multiple devices that you have here. We will have, but you have here. And so we then talk about talking with patients about the equipoise of a handful of pills versus a device that can be used that gives you similar results. The most important thing about this is the certificate of compliance. If you give somebody a device, they are compliant. No matter whether it's 30 days later, no matter they've had too much alcohol the night before, it doesn't matter. The device becomes part of the framework. And so as part of that issue of talking with patients about the alternatives, the good things, the bad things, we can say everybody that gets a device is going to have a certificate of compliance. It can be used in patients who could be treated with warfarin or NOACs. It can be used to patients who either choose not to be or chose not to be treated with warfarin or NOACs. It can be used in patients with contraindications to warfarin or NOAC, and increasingly it's used in concert with ablation, TAVR, mitral clip. It is going to be the big deal going forward. Now that we have addressed the issue of left main disease, bifurcation disease, the future of our field is going to depend upon expansion of those things that you do, that you offer to patients to treat their unmet clinical needs. And left atrial appendage occlusion is part of that unmet clinical need that you should be in as part of your future as an interventional cardiologist. Thank you.